is from Medicine 4. Dr. Alsy will be presenting on the mystery of rogue inflammation.
I'll be presenting on behalf of Medicine 4. My topic for today is mystery of rogue inflammation. So I'm talking about Mr. S from Kerala, 49 years old, who has come with recurrent wheals for 6 years, recurrent bilateral ankle joint and swelling for 4 years, skin changes over bilateral ankle region for 4 years, burning sensation in bilateral legs for 2 years, and loss of weight of 12 kg in 4 months. So his timeline of events were in 2018, he started having insidious onset, intermittent wheals and generalized stitching all over the body, followed, which was not treated. In 2019, he had insidious onset, gradually worsening pain in bilateral heel region. Again, in 2021, there was insidious onset, worsening of pain in bilateral ankle joint and swelling, and sudden onset swelling in the pain swelling and pain in the right testicle. In 2022, there was another episode of pain and swelling in right testicular region. And in 2024, July to August, he had again the same symptoms of severe pain and swelling in bilateral ankle joint with skin changes, burning sensation, pin and needle-like sensation around the ankle joint, and swelling in the left testicular region. So he came to us on 2024 August, and again he had a relapse of symptoms in October 2024, which is the worsening of pain in bilateral ankle joint associated with new skin lesions in the ankle and swelling in the right testicular region. So his past history, he had history of steroid-induced diabetes. He was a reformed smoker for the past 6 months. And for the above mentioned history, he was treated outside with multiple drugs like methotrexate, prednisolone, azathioprine, deflazacort, as well as he had taken Ayurveda in between for 2 weeks. On examination, his heart rate was 90, BP was 100/60, he was afebrile. He had bilateral pitting pedal edema, swelling around the ankle joint, left more than right side, hyperpigmented patches over both ankle joints, hyperexia over the skin of the foot and lower third of the leg. Straight away to the CNS examination, his cranial nerves were normal, tone was normal, power was normal, bulk was normal, cerebellum, there was no, the large signs were negative. Bilateral touch was normal in the feet. There was altered sensations in the bilateral feet. There was tenderness over the shin bilaterally. He had three tender joints, bilateral ankles and right knee. Swollen joints and tender joints, right foot, medial and lateral malleolus, mid-tarsal squeeze tenderness on the lateral side. There was no MTP tenderness. Left foot, he had a lateral malleolus tenderness and mid-tarsal squeeze tenderness, ball of great toe tender as well. So other systemic examination was unremarkable. So we were thinking in terms of a symptom complex of skin lesions with oligoarthritis with sensory neuropathy plus epididymo orchitis. So our differentials we considered according to our symptom complexes were autoimmune diseases as the first one because of a multi-system involvement with medial vessel vasculitis as the medial vessel vasculitis or a small vessel vasculitis, crystal arthropathy, infiltrated disorders like sarcoid amyloid, malignancy with paraneoplastic symptoms, infections like disseminated TB, or a uncontrolled diabetes causing a vasculopathy or neuropathy. So on evaluation at presentation in July, when August when he came, his HB was 12 and his total counts was 9,000 with platelets of 3.56 lakhs. At presentation, his CRP was 28 in August. ESR was 39, vitamin B12 was 563 and folic acid was 2.1. At that point of time, his autoimmune workup was negative, ANA was negative, anti-SSA, ACE, ANCAS complements were negative, LDH was normal, his urine protein ratio was normal as well. So at this point of time, we couldn't find any features to call it as a vasculitis, or we couldn't label it under any name. So we had asked for his predominant symptom being epididyma orchitis, testicular pain and swelling. We had asked for a urology consult, and we had managed it with antibiotics at this point of time. However, his symptoms worsened and he came back in October. At this point of time, his HP had dropped from 12 to 9.7, and his CRP had gone up from 28 to 103, and ESR from 39 to 80. So his metabolic and renal hepatic parameters were all were normal at previous admission and this admission. So at first admission, we had done a malignancy workup, which did not show any evidence of malignancy in PET. We had done a skin biopsy at that point of time, which did not show any features of vasculitis. We had done an ultrasound of the scrotum, which had left hydrocele with epididymitis and funiculitis. So in this background, ruling out a malignancy and autoimmune, we had treated him like a orchitis and asked him to review if symptoms persist. And his nerve conduction study also had shown mild sensory axonal neuropathy. At review, after worsening of symptoms in October when he presented back, his NCA study had shown sensory motor axonal polyneuropathy of both lower limbs and small fiber neuropathy involving lower limbs. And we had done a nerve muscle triple biopsy of skin, nerve, and muscle, which is skin biopsy showing features of vasculitis and nerve biopsy showing a transmural infiltrates of lymphocytes, and muscle biopsy showing a scattered atrophic fibers. So with the clinical as well as the clinical histopathological events, we have diagnosed as a medium vessel vasculitis, polyarthritis nodosa with cutaneous manifestations, polyneuropathy, oligoarthritis, and epididyma orchitis. So there are literature reviews of over decades, there are literature reviews of polyarthritis nodosa presenting with orchitis. So I'm going to talk about polyarthritis nodosa. It was first described in 1866 by Kosamal and Mayer. It is a multi-system necrotizing inflammatory vasculitis affecting the medium-sized vessel and occasionally small muscular arteries. It is not associated with antibodies, and in the vessel there is transmural inflammation. It can be a limited disease or a systemic disease. Again, it can be primary or secondary. In case of secondary, it can be secondary to connective tissue disorders, leukemia, or any infection. So ACE criteria, there is a criteria that is for classification of polyarthritis nodosa, weight loss of more than 4 kg, libido reticularis, testicular pain or tenderness, myalgia, weakness or leg tenderness, diastolic blood pressure more than 90, elevated urea or creatinine, hepatitis B virus infection, arteriographic abnormalities, or a biopsy showing necrotizing vasculitis in arteries. So our gentleman had weight loss. He had libido reticularis, testicular pain, which is according to the criteria more than 3, gives up sensitivity and specificity to 80 to 87%. So treatment of polyarthritis nodosa, we divide into an active disease, severe or a non-severe disease, and an active disease. Severe disease is when there is vasculitis with a threatening end organ damage, and non-severe is when there is no life-threatening end organ damage. So in non-severe disease, the induction therapy is either by a non-glucocorticoid suppressive agent with the glucocorticoid or glucocorticoids alone. And in clinical remission, if there is clinical remission, we can switch over to a non-glucocorticoid immunosuppression over 18 months, or clinically look for response and then titrate. If there is no response, then you have to go for second-line agents like cyclophosphamide, or if there is transition from non-severe disease to a severe disease. Whereas in severe disease, we will give high dose oral or pulse glucocorticoids with cyclophosphamide or glucocorticoid alone. And again in remission, glucocorticoid, non-glucocorticoid immunosuppressants over 18 months, and look for remission. If there is no clinical remission, then then you will have to add on to another agents. Thank you.
Thanks, Alsy. Are there any questions or comments from the audience? I think from the first visit when he came, it was clear that this man has something more than an acute infection. It's been going on for many years. And then the question is just about proving it. I think if you have an arthritis and a neuropathy, definite neuropathy, and this orchitis, I mean, it's definitely was a vasculitis, but it's always a little difficult to find that biopsy proof usually. I wasn't really aware, but if epidermolysitis is a typical picture in a typical feature of PAN, then yeah, that would have even strengthened your resolve more that you need to somehow find this biopsy.
Yes.
He didn't have any active skin lesions.
He did have active skin lesion, but when he presented, he was disease modified. He had received many years of steroids from outside. And second thing, because Euro felt it was more like an infection and he was not willing for a biopsy at that moment, he said, we'll give a trial of antibiotics and then to come back.
Yeah, I mean, I understand, and probably you did do a skin biopsy and it was initially negative.
Yes, it was negative for vascular.
Yeah, so I think you just needed to wait for those skin lesions to appear. But yeah, overall, this picture of recurrent epidermolysitis, yeah, it fits in with the vasculitis rather than, yeah, an infection. So next we'll have Dr. Sharon presenting on behalf of Medicine 5.